This patient was referred to me for endodontic treatment of tooth number 30. Patient says his dentist told him that tooth needed a root canal. Okay, now, how many times should I tell you guys not to rely on just one PA for diagnosis? All right. First of all, yes, tooth number 30 very well could need a root canal, but right now you can't see anything. Patient says he has no symptoms. All right. So why would the tooth number 30 need a root canal? All right. So there's a crown on the tooth. Okay. So take multiple angulation PAs. Let's take a look at another PA. Okay, a little bit better. You can see there's a large recurrent decay right here. Also tooth number 31. There's a big cavity right under the crown right there. Let's look at another angulation PA. Look at this one. You can see the recurrent decay on tooth number 30. So tooth number 30 also definitely needs a root canal. Also, what is this anatomy? This is radix entomolaris, right? Okay. Look at the decay on tooth number 31, mesial. All right. What is this? So, number 29 is an abutment to a bridge. Look at that. Huge periapical lucency. I asked the patient, well, tooth number 29, this tooth also needs a root canal. Patient says, oh, I had no idea. I'm like, your dentist never told you about this? No, I didn't know. My dentist told me, come to see you for this, tooth number 30. Again, you can see the decay right there. So I told the patient, unfortunately, you will need 2 root canals. So number 30 and number 29. So taking multiple angulation radiographs helped you figure out why this patient needs a root canal on tooth number 30, showed you the anatomy of this tooth being radix entomolaris, showed you the decay under the crown of tooth number 31. You saw the periapical lucency associated with tooth number 29. The other thing that you always need to pay attention to when you have decay like this, 2 teeth that are in contact like that, look at that. I probed this area with 6 millimeters with BOP, and I asked the patient, that's a food pocket, isn't it? And he said, oh my goodness, I get food trapped here all the time, and I have such a hard time cleaning out all the food here. Well, that's how he got this cavity here. But no one has ever addressed this problem, this food pocket here. So imagine if I hadn't told this patient about this problem, okay, the food pocket, and the fact that there's actually a solution for it. What would have happened? Okay, so just think about that. He would have gotten a root canal here at my office, right? Then he would have gone to his dentist. His dentist would have cut the crown off and cut the crown off of number 31 also, and made 2 new crowns. All right, but the food pocket, that pocket is still there, collecting food. What will happen? A few months later, a couple of years later, he would have the same problem that he has right now, these recurrent decay. He would have them again under his brand new crowns. All right, so you have to do a thorough examination, evaluation. You owe it to your patients. You're not just a drill and fill doc. You know, a monkey can do that. This patient was referred to me for endodontic treatment of tooth number 18. Patient states tooth is sensitive to heat, to cold, and to biting. She saw her dentist and was referred to us for endodontic treatment of tooth number 18. All right. So now imagine how easily you can just misdiagnose, treat the patient, charge the patient, and then the patient will end up losing the tooth. Okay. So I examined the tooth, percussion, tender, palpation within normal limits, probing. Guy, girl, you need to probe. I saw a fracture line here on the distal marginal ridge, extended onto the distal wall and extended. it extended apically. All right. I used my surgical operating microscope and I was able to confirm that fracture line. Distal marginal ridge, extending distally onto the distal wall and apically. Probing 1 to 2 millimeters all around along the fracture line on the distal, 6 millimeters. On the distal lingual, 6 millimeters. All right. You're doubtful. You think maybe that's the normal probing of a tooth such as this one. Well, go ahead and probe exact same tooth on the lower right side, tooth number 31, and that's what I did. I probed tooth number 31, 1 to 3 millimeters all around. So the 6 millimeter pockets here are abnormal. And the fact that the tooth hurts to chewing, to biting on, the fact that there is a fracture, the fact that the probings are 6 millimeters along the fracture line and on the distal lingual of the tooth, all of that points to this tooth being a split tooth. So RCT buildup and a crown has a very, very guarded prognosis for this tooth. So I went over that with the patient. Very, very guarded prognosis. Or you can just go ahead and extract the tooth. And I told the patient I will probably like her to choose the extraction approach. But if she really wanted me, I would try it. I would try to do the root canal and all that stuff. But patient said, no, I'm just going to extract it. There you go.